Welcome to today's Explainer. We're jumping right into what is honestly a fascinating historical detective story about the true origins of our long modern lifespans. Now, most of us naturally credit hospitals and high-tech medicine for our longevity, right? But the historical data points somewhere else entirely. So, let's look at the evidence. Okay, let's dive into this. It's a deeply held assumption that clinical medicine, the doctors, the pills, the surgeries, is the primary engine driving our historical decline in mortality. We kind of have this mental image that humanity was just dying off helplessly until modern science swooped in to save the day. But is that actually true? To find out, we have to look at the groundbreaking work of one specific demographer. Enter the McKeown Thesis. Thomas McKeown was a pioneering physician and demographer who completely shattered those conventional medical beliefs with a shocking analysis of population health trends. Looking strictly at the historical data, he revealed that the massive drop in deaths from infectious diseases, think tuberculosis and pneumonia, well, it began long before any effective medical interventions even existed. Now, what's really interesting about this timeline is the twist it reveals. Infectious disease mortality started plummeting way back in the 18th century, yet the major medical breakthroughs arrived much, much later. I mean, sulfonamides didn't show up until the 1930s, widespread antibiotics in the 1940s, and advanced surgical interventions in the 1950s. The deadliest historical bugs were being defeated decades before we actually had effective therapies for them. No way, right? To explain this massive gap, McKeown split historical health determinants into two distinct realms. On one side, you have medical measures, your clinical treatments, therapies, and technologies. On the other side, you have environmental influences, things like hygiene, sanitation, nutrition, and overall standard of living. And the data revealed a really stark reality. Those big medical milestones only arrived after the vast majority of our mortality decline had already been achieved by the environmental factors. So what were the real lifesavers? It was all about foundational environmental upgrades. Better agriculture meant better nutritional status, which fundamentally altered the ecological balance and strengthened our host resistance against pathogens. Meanwhile, we got clean water systems, proper sewage disposal, and improved housing. These physical changes directly interrupted disease transmission. We literally just stopped giving the bugs an easy path to infect us. Demographers actually call this organically following the trend. Basically, as overarching macroeconomic conditions, standard of living, and sanitation organically improved over time, mortality curves naturally sloped downward with them. Society progressed, the environment became far less hostile to human biology, and humans simply stopped dying at massive rates. It was a structural shift. Which brings us to a critical pivot point in our story. If basic sanitation and nutrition were the real heroes of the 18th and 19th centuries, what is modern clinical medicine actually built for? I mean, we're definitely not bashing modern medicine here. It has immense value. But to understand its true power and its limitations, we really need to unpack the foundation of modern healthcare, which is known as the biomedical model. The first core foundation of the biomedical model is reductionism. This is the principle that to understand a complex phenomenon, like a human illness, you just need to reduce it to its most basic biological parts. You're not looking at the whole ecosystem of a person and their environment. You are aggressively zooming all the way in to find a specific cellular malfunction or genetic mutation. That leads directly into the second pillar, mechanism. This is treating the human body exactly like a complex biological machine. Think about it. When your car breaks down, you don't ask about its feelings or its living conditions, right? You locate the faulty gear and you repair or replace it. Under this model, medicine becomes entirely about pinpointing and fixing those broken biological parts. And the third pillar is mind-body dualism. Inherited from Cartesian philosophy, this is the historic separation of mental and emotional states from physical pathology. For example, if you visit a doctor for a terrible stomach ache, they'll run labs to find a physical ulcer, but they rarely have the framework or the time to investigate the psychosocial stress that might actually be causing it. The body and the mind are treated in entirely separate silos. Now, to be absolutely clear, treating the body as an objective machine has yielded undeniable triumphs. We owe germ theory to figures like Louis Pasteur. It helped eradicate smallpox, gave us breathtaking diagnostic precision with MRIs and genetic sequencing, and established the gold standard of randomized controlled trials. For surviving acute trauma and very specific internal breakdowns, this model is literally a miracle. And this brilliantly illustrates exactly where the biomedical model shines and where it severely falters. For a bone fracture or a targeted bacterial infection, the machine approach succeeds flawlessly. But for complex, multi-causal chronic illnesses, things like fibromyalgia, chronic fatigue, or mental health conditions driven by psychosocial stress, the model struggles. These are ecosystem problems, and they just don't have clear-cut biochemical markers to fix.
Because of that, this intense focus on biological mechanics carries a massive risk: over-medicalization. This is the iatrogenic effect. By treating the body strictly as a machine, we can accidentally pathologize normal human variations, or the standard aging process. If we're constantly searching for a biological part to fix with a pill or a surgery, we risk unnecessary medicating without ever actually improving a person's real quality of life.
But perhaps the model's most massive blind spot is its neglect of social determinants. Epidemiological data consistently proves that poverty, poor housing, your employment status, and your emotional well-being profoundly shape disease incidence. But because these aren't internal biological mechanisms, a purely reductionist approach misses them completely. You simply cannot fix poverty with an MRI.
Which brings us to a huge modern challenge. Remember how historical populations organically followed the trend of improving living conditions? Well, today, with a massive rise in chronic, stress-driven, non-communicable diseases, organic improvement just isn't cutting it. We have to bend the curve. We need an intentional, active deviation to suppress this escalating crisis by actively designing better psychosocial environments for people.
So the crucial point is this: the biomedical model remains absolutely indispensable for acute pathology. We need it. But its strict reductionism leaves it completely unequipped for modern health realities. To fix the machine's shortcomings, we need a biopsychosocial shift, integrating the biological insights of the machine with the psychological and social perspectives of the human ecosystem. Health isn't just the absence of disease, it's a whole person thriving within their environment. Which leaves us with a lingering, pretty provocative question to chew on. As the diseases we face shift away from acute infections and more toward complex, chronic, environmentally driven conditions, is our current medical system, which was built brilliantly for the 20th century, actually equipped for the complex illnesses of tomorrow? Understanding the history of how we got here is just the first step toward figuring that out. Thanks so much for joining this explainer. We'll see you next time.